And our new social media campaign is Choosing Wisely Snapshots. We'd like to share your story. We'll share a story, great or small, if you're passing out 5 question cards or whether you have a major implementation in process. We'd like to share it and learn something about what you're doing. We'll be sharing it through Twitter, Facebook, Workplace, and our newsletter. Before we begin, I also want to cover a few logistics. This meeting will be recorded and shared. While our presenter is speaking, we will have the lines muted to reduce unnecessary noise, but we will unmute at the end of the presentation for questions and comments. Please feel free to enter questions in the chat box throughout the presentation. And now I'd like to turn it over to our physician consultant, Dr. Lisa Letourneau.
Hi, Kelly. Thank you, and welcome everybody on the call. Also delighted to join you today and delighted to welcome Dr. Reshma Gupta as our featured speaker today. So Dr. Gupta is an assistant professor and serves as a medical director for population care and value at UC Davis. Also serves as a senior advisor for the Centers for Medicare and Medicaid Services. Dr. Gupta's research and interests focus on health system innovation, quality improvement, and education to better define and improve the culture of delivering high-quality care at lower cost for patients and systems. She received her medical degree from UC San Francisco and trained at the University of Washington. She also is a former Robert Wood Johnson clinical scholar. So with that, Reshma, I will turn it to you. Thank you.
Great. So thank you so much for having me. I'm really excited to speak with you all and share some information about this high-value care culture survey. So today we're going to be talking about creating a high-value care culture and how we can better understand how to measure and target improvements by addressing culture through our initiatives. Just a quick slide on some of the partners that helped develop this survey from support from the ABIM Foundation, Cost of Care, and the Robert Wood Johnson Clinical Scholars Program. Today we're going to be discussing 2 major areas. One, discussing the role of culture in creating a high-value care environment in general. And then 2, actually getting into discussing the survey itself, the purpose of it, how it was developed, and mainly focus on the approach to understanding results and how to operationalize using the survey in the work that we all do. As some background, organizational culture is like the water surrounding fish. It is all around us, yet can be difficult to perceive from within. This culture or imprinting, essentially defined as a system of shared assumptions, values, beliefs, or norms that exist in our environment, creates a very powerful undercurrent that shapes the practices of all healthcare providers and contributes to overuse within our healthcare systems. So recent work to improve healthcare value focuses on creating guidelines and algorithms such as appropriateness criteria. Although it's important to codify best practices, we must recognize that even with the guidelines in place, we're still swimming in that same cultural water that's guiding us and our colleagues that we work with in our own local institutions. One thing that we've realized from literature, and there's more and more that comes out on the influence that culture has in high-value care ordering practices, but we know that 97% of emergency medicine physicians, for example, reported unnecessary imaging testing, which the authors noted reflects a cultural response to uncertainty rather than the physician's lack of knowledge or judgment, and having a culture for improvement really correlates with clinical outcomes. Authors such as Zhang and other colleagues found that institutional culture and policies similarly affect whether medical trainees feel compelled to offer a choice of resuscitation, even when all clinical situations, regardless of whether they believe it was clinically appropriate. So again, the culture component taking a deep dive here. And in systematic reviews, we found consistent association between positive organizational culture and improving outcomes such as mortality. Institutions we know who have scored higher in similar types of surveys, such as patient safety culture surveys, have also shown improvements in clinical behaviors and patient outcomes across the health system, and this includes infection rates, error rates in the inpatient setting, and also mortality. So to change clinician behaviors in a way that we deliver the best care at lower cost, the culture within healthcare microsystems needs to be meaningfully addressed in one way or another. This is one of my favorite slides when we really think about culture. It's really where we focus our hidden curriculum. where we are focused on in balanced way on identifying rare cases, where our sins of omission are often greater than the sins of commission. And there's a misperception of what's in patients' interest regarding considering costs being aligned or not aligned. This is a quote from one of my mentors and a number of us as part of Cost of Care, Dr. Bob Wachter at UCSF, who mentions this quote: "Organizations will generally try to create needed change without addressing for, budgeting for, or having the patience for culture change. God bless them if they are successful. The vast majority won't be. Leaders cannot create culture, but they must create the conditions for a great one to emerge." So I'm going to jump into the survey itself and provide a little bit of background about how it was developed and then more about how we want to use this going forward. So this survey was developed a number of years ago, back in about 2015, and there was a panel of experts that we convened on a conceptual model for what goes into high-value care. The potential survey questions essentially represented these conceptual model domains that included physician or clinician characteristics, patient characteristics, national guidelines and regulations, organizational culture, organizational structure. All of these go into eventually how a physician predicts cost and quality outcomes to a patient and health system, and then eventually their decision-making and value-based decision-making. So if we look at pulling from these domains, we developed surveys by identifying items that represent a number of these different components. And we held a modified Delphi process with 28 key stakeholders that represented 5 regions of the U.S., 11 specialties, 4 hospital types, various training levels from very senior faculty all the way down to students, and key organizations, including representing government, insurers, schools, and many others. These were tested at 2 sites, the surveys, both amongst hospitalists and residents. And essentially what we found, and I'm sharing here the website of where you can actually find the survey and a lot more information about how this was created, is as a tool, it was created to measure culture amongst frontline clinicians. So these are frontline nurses and physicians that are making clinical decision-making and value-based care. And it's often done at the division or practice level. We believe it will provide nuanced information at a very local level and be useful for identifying targeted interventions that address culture change. So hospital divisions, clinical practices, training programs with value-based performance metrics that may not be at goal could potentially use this survey to identify where needed behavior change may be. So in addition to health system managers, the high-value care culture survey could be helpful to other key stakeholders as well. For example, health system and training program leaders might use it to identify the process or structures that best support a high-value care culture. Researchers and policymakers might evaluate and compare the cultural component of value within health centers over time. And these efforts would be similar to how a patient safety culture surveys have been widely used to monitor and improve patient safety. Experience with patient safety surveys show that culture varies considerably between organizations and within individual units or clinical groups. For an organization struggling to improve value in its care, results from this type of survey might become a key intervention to target and also a center component for learning health system within a medical center. Ultimately, the survey has 4 key domains that you can see on the left of this slide. And again, I provided the website to access the survey. The first is leadership and health system messaging. The second, data transparency and access. The third is comfort with cost conversations. And the fourth is having a blame-free environment. These capture specific areas for targeting value improvement interventions. In evaluations, scores differed consistently between our initial pilot sites, where our Center B actually had a higher overall high-value care culture score, and as well in 3 of the 4 individually domains tested. The high-value care culture survey also positively correlated with an institution's CMS value-based purchasing scores. Overall, health system leaders and program directors can use the survey to identify these targeted improvement areas and actually monitor improvements in culture over time, and also provide initial support of reliability and validity for this survey in this evaluation. We also tested this in a bigger study across 12 sites in the state of California that included internal medicine residents and hospitalists across university, community, and county medical centers. And again, what we found is a pretty strong correlation, greater than 0.7 in Spearman ranking, between value-based scores and their high-value care culture survey scores. I'm going to jump into the domains and talk a little bit more about how to use these. So our largest domain is leadership and health system messaging. This area consists of 18 questions, and as it mentions on the slide, covers and discusses engagement of frontline clinicians, visibility of leadership, communication styles, role modeling, and having formal training in the areas of value-based care. What we know is that lower scores among individual questions in this factor can identify areas of improvement, such as increasing formal training related to value, providing transparent access to quality outcomes. Leaders can explicitly state that providing high-value care is a priority, and may provide specific resources or incentives related to value improvement activities. In academic centers, creating and supporting leaders that bridge healthcare delivery and education silos may prove to be a critical mechanism for spurring culture change and improving these scores related to this domain. Since this domain has many questions, it's actually very important to review the specific questions for which your own clinicians or staff are reporting lower scores and be able to discuss these performance with your team. So I'm going to provide some examples, actually coming from one of our sites. I won't mention which site it is, to give you an example of how people scored and then how they develop interventions around it. So for example, one of the questions in this domain is, supervisors in my group review my performance based on decisions that will lead to delivering quality care at lower cost. And I just want to mention two things around the specific wording that's used in the survey. We use the wording my group, and part of that is for flexibility. My group could relate to a division within a specialty, a specific practice or clinic. It could be a unit within a hospital setting, or it could be amongst a residency program. And residents may fill out the survey and consider their group their colleagues in terms of their other residents and counterparts. Another definition I just want to mention here is we're using the words quality care at lower cost. And this was done after doing some qualitative interviewing as we were asking these questions, and we realized that a number of people on the front line that were answering them were very confused by the word value itself. And this terminology seemed to be the best one that made sense to get at the core of what we're asking. So again, for this item, more than half of physicians disagreed that supervisors reviewed value performance, and data on value performance can be provided to supervisors, and expectations can try to be established to incorporate this into routine evaluations going forward. Another example here is my group is actively implementing projects that address costs of care. So again, here we see some opportunities where nearly, a little less than half of the physicians disagree that their group is actively implementing these types of projects. So having leadership encouraging these types of initiatives, if it's through non-financial incentives or financial incentives, competitions, resource support would be vital to create some visibility here on this item. Another one that I'll share under this domain is my group openly discusses ways to deliver quality care at lower costs within my group. So again, you see here over a third of clinicians at this site relayed these answers as agreed. Leaders could, again, create extra time in meetings, have evaluations, and actually include it in part of performance reviews with the proper data provided to be able to discuss when initiatives are being held up in value-based care with the clinicians at the front line. One last one for this group. My group has formal training to address high-value care. 46% of clinicians disagreed that their groups had formal training. So be it from grand round types of sessions, integrating other kinds of resources and modules that bring in training around high-value care, the other resources that are actually skill building for clinicians in high-value decision-making. When there's initiatives focused, such as reducing overuse of, brand name proton pump inhibitors for an institution, their ability to discuss this in terms of cost and in terms of what the decision-making protocols around clinicians can be highly valuable to affect this kind of question. I'm going to go to the second domain, which is data access and transparency. This item actually consists of 2 questions, which I've listed here. And the second factor actually focuses on the availability of cost data itself for frontline clinicians. I'm going to jump into one of the questions that we list here as an example. When clinicians in my group have questions about cost, they may know where to go to find answers. Here we see that there is agreement about lack of access to cost information. And I feel like this is actually a result we found across most of our sites, across our 12-site study. And what we know is that, this data is often challenging to get a hold of, but centers with lower scores in this domain may need to prioritize creating reliable databases, provide this data to patients who have already determined local costs by virtually every service in them, an example being University of Utah and a few others. It may be important to talk with your health system leaders to find out what is available to make this work, to make it more accessible. Oftentimes, identifying the top 10 labs, imaging studies, there is relative cost direct data that finance departments do have. Alternatively, if that is challenging to get a hold of, some institutions have used comparative costs or standard charges from payers for common key target areas. This is often easier in institutions where there are payer-provider relationships, and so you get a better sense of what those numbers are. But even the relative costs for other institutions can be very useful with the right resources. Our third domain is comfort with cost conversations. This includes 3 questions, which I've listed here at the bottom, and really covers the comfort of clinicians to have these conversations with patients themselves. As an example, clinicians in my group are uncomfortable discussing costs of tests or treatments with patients. And here we often see quite a bit of variability in responses, where only a third of respondents disagree with this statement. Based on regulatory pressures and perceived needs, training programs often will teach residents how to discuss challenging topics such as domestic violence, sexual histories, advanced care planning. Similar programs could focus on cost conversations, introducing into patient-provider discussions by using standardized financial harm screening tools or via formal training using standardized patients or interactive modules. Recent studies have also suggested that patients are increasingly worried about the cost of medical bills for routine care, and 2/3 of patients actually say that they wish that they could talk about costs with their physicians. There's quite a bit that probably could be done in this area to build this item. And our last domain is around having a blame-free environment, which again consists of 2 questions listed here at the bottom. Here we see blame may involve, again, a resident being criticized by an attending for failing to order a low-value imaging study, or the threat of malpractice suit after a reasonable or evidence-based decision to forego a test. We therefore included the questions listed here. Centers that score low on this domain will likely focus on promoting evidence-based practice, giving clinicians information so they can fairly weigh the risks of defensive medicine with the benefits. And medical centers that also create a non-punitive environment in which discussions of errors or poor outcomes are not unduly biased towards defensive medicine can often be helpful. So in this example, we have in my group, clinicians fear legal repercussions affects how often they order unneeded tests and procedures. Here, nearly 50% of physicians agree that clinicians fear these repercussions, and it affects how often they order tests. Consider focusing on, in this situation, promoting evidence-based practices, as we've discussed. And then the other is there are a number of trainings about how to redesign the culture around a punitive environment that I'm happy to provide resources to later on if this does become an issue. So one last slide I do want to share is about how we approach our data. There's no goal benchmarks for the metrics at this time, and part of it is because these are somewhat cultural questions in the sense of what is appropriate. So we can use this survey to compare to other hospital groups. We recommend instead that you as a group, as you're embarking on this work, sit down and actually use the results to identify potential areas for improvement and to monitor and measure success. In some of the examples that we heard, we found 30% of providers are saying that they do not have seen success out of value improvement initiatives. And so while 2/3 of people are saying that they do see it or that they are in between and they're not sure, the question will come, is 30% good enough at your institution or not? The second bullet here is that there are complex issues in improvement that will require additional infrastructure. Some of the responses to these items may require some additional resources in this way. Well, we don't necessarily expect to get to 100% of these metrics for that reason. This is another area where, if there's issues in culture that are being identified, discussing it with division leadership or hospital leadership will be key. Again, we suggest thinking about how best to administer these surveys. One of the ways that we have found it being best to be completed is actually delivering these surveys in required meetings in which you get a handful of minutes to have attendees fill them out, and using online formats. So on smartphones, they are able to complete them. When we time these surveys, it's about 26 questions long, it times out to just barely over 2 minutes to complete the entire survey. And we also suggest administering at baseline as well as at 6 or 12 months. And I think that timeline really depends on what intervention and how fast your intervention is being implemented. If you expect to see change in the item of culture that you are deficient in a more rapid speed, 6 months might be okay. Otherwise, it might require 12 months to actually hypothesize a change there. And then one thing to note is when you're scoring this scorecard, there are a few questions, about 5 of them that are, at the end are reported in the negative. And so the scoring does reverse in those to get the proper score. Each of those 4 domains, we average the items to create a domain score and ultimately average the domains so they are weighted equally. So in conclusion, we hope that this high-value care culture survey will help you to begin improving culture at your institution, and I'm happy to take any questions.
Great. Well, thank you very much, Reshma. Can you hear me? Okay. Sorry, I just had a little phone issue. Thank you so much for that. Are you hearing me okay?
It's
I think if you spoke just
muffled.
a little, yeah.
Yeah, my phone kept bumping off. I'm gonna.
Lisa? Well, while we figure out Lisa's technical difficulties, I'm going to maybe throw out the first question, and also invite everyone in the chat to ask some questions. But one of the things that I want to ask, and it might be a hard first question, is there's some resistance to the idea of cost conversations, particularly in the high-value care. What do you think will compel some organizations to think about cost maybe in broader terms so that this might be helpful?
Yeah, I think one thing is I think having cost conversation is not a light issue. And I think I mentioned this a little bit in kind of some of the items where we do discuss this, is that we have not traditionally trained, so this includes from students to faculty to community practices, our clinicians about how to have these conversations. And I think it really truly is like these topics of domestic violence, where there is a sensitivity to the words that we use. There's been papers published about choosing your words wisely, similar to choosing wisely. And I think it's required in this setting. When we talk about cost, is it a cost? Is it a charge? Is it the cost to the health system? Is it the cost to the patient and their out-of-pocket costs? I think another component around that makes people very uncomfortable is just not knowing that terminology. I think the second area that comes out of discomfort is not knowing what to do. So if we're screening patients in front of us for financial harm through a screening tool, or we're identifying that they are at risk of financial harm through the tests or procedures or medications we're doing, we don't necessarily have care pathways to deal with their financial risks the same way we do with their medical risks right now. And so I think cost conversations fits really well when the frontline clinicians and care teams have forensic support. So being able to know, almost like in conversations about domestic violence, we'll do the screening as clinicians at the front line. But once they're identified as potentially at risk for some of these, there's a support team or a care team that helps to get them where they need to go and the infrastructure within the health system to build that, which might involve developing pathways that include financial pathways to billing and understanding what before a test or treatment, during a treatment, and afterwards, what that might look like in terms of cost for the patient. So I think it's not just conversations, cost conversations in isolation, but it's kind of a system that needs to come together to support that the best way. At the front line, doing the trainings is often the best way to start. But there does, I agree with you, from the health system perspective, need to be that extra infrastructure to make sure that frontline team is actually supported in the right way.
Great. I'm going to ask you a question from the chat box, but I do want to let people know that if you click the red microphone next to your name, you can unmute yourself if you'd like to ask a question aloud. And also, please feel free to use the chat box. We do have a question in there right now. Do you have any guidance on how to determine how many surveys to distribute to have some measure of validity as well as an acceptable response rate?
Right. So, in terms of our study and the validation that we did, we got a large number of surveys, almost 1,000 surveys that we used for the formal validation. I think at the local institution, it's actually surprising how few that you need. One of our sites actually had 8 hospitalists, and while statistically it was challenging to kind of incorporate that low of a number in our statistical analyses, 7 out of the 8 members had almost the exact same scores, individually identifying where there were cultural gaps. And the one person who didn't only differed in 2 questions. So this is where I kind of come to the phase of saying that sometimes we're limited by the number of people in our, and with the statistical analysis we did, even having a number as low as 8 still actually had a correlation with their value-based purchase scores compared to other institutions. So I wouldn't say that there's an absolute minimum that you need. We generally, in terms of operationalizing the survey, will often get a certain percentage. So if we're able to say that even 30 to 50% of a division is able to complete them, you'll get a pretty good idea of where the gaps are. I think in terms of research and publication, that goes into different guidelines of often trying to get more than 65% of surveys completed. But in terms of an operational hat, you will start finding common themes, almost like qualitative research that we do, come out very quickly with just a few surveys in hand.
Hey, Reshma?
Yeah.
So this is Tim. I actually put in that chat box, but thank you for that. I think you answered it, although I guess the follow-up is, what's the statistical test to show that there's very little variation that validates a lower survey size?
Mm-hmm. So statistically what we did in terms of our different sites, including that one of 8, we're using our alpha, and we also, in terms of our confirmatory tests, we use a Bentler-Bonnet norm fixed index. Those were the 2 that we used in terms of our statistical analysis. I think in terms of correlation of what we did, which was correlating to an institutional value-based score. For that, we use a Spearman rank correlation. I think amongst individual providers, though, this isn't something where, you know, when we're operationalizing the work in terms of implementation, that having, again, only 8 people, being able to provide a score in which about 80% of our alpha was similar, was very key to being able to say that that low of a score, you're going to probably find very similar results. Again, I think there are opportunities in terms of using the survey and formally in a research setting, evaluating amongst other populations, in which I think doing additional confirmatory tests across other groups. The initial standardized tests that we did were across hospitalists and internal medicine trainees. But I think there's opportunities to validate this kind of survey across other groups such as emergency medicine physicians, pediatrics, other specialists as well.
Thank you. And then if I could just, one quick follow-up question is, in your 2016 study, which I read, since that time, have you or anyone else been able to validate that changes or improvements in the score over time also correlate with improvements in either quality or financial metrics related to high-value care? It's basically the business case, right? Is there a business case that's been done yet to show that changes in culture also then correlate with performance improvements and potential cost savings?
Yeah, no, that's a great question. I think at a very high level, based on the research methodology, at an institution level of an outcome, such as value-based purchasing score or other government or payer-based cost standards there, it's challenging because it would require, if you think about it, probably over 100 of institutions, if you look at the data points and having an N at that level. So you would be doing surveys at each institution to get kind of the average score, and then need that many institutions to do it. So at that level of a study, it hasn't been done. But where we have seen is where individual institutions are using this amongst their providers for specific initiatives. So for example, there have been a couple examples of practices, so in the outpatient setting, using that same example of proton pump inhibitors that have tried to, the initiative was to go from high cost brand name medication to generic. And they did it by testing culture and kind of had an education platform and a multi-component intervention. And there they saw a reduction, an improvement in the high value care culture surveys. Overall score as well as in the leadership messaging. The other one that was significant for them was about the cost conversations. So those two subdomains in the overall domain were statistically significant in improvement. And what they did see is almost a 20% reduction in the initial ordering of high cost to going to generic proton pump inhibitors. And then that was at 6 months. And then after a year with a few more behavioral health interventions through electronic medical record, they actually saw another improvement in the culture survey score and another reduction almost down to another 30% in prescribing proton pump inhibitors that were high cost. We've had a couple other examples actually in Australia that have used this survey, and we have not seen the results of those, but there are kind of practice-based ones that we have seen. And I think on the website, when you look at, there are some groups who have posted their experiences with the survey. Some of them come out of there as well. I haven't seen them in published literature, though, over time.
Thank you. Great, Reshma. This is Lisa Letourneau. Sorry, we had a little audio issue here, but I had a question. Thank you. I had a question. Are there times when you would advise organizations not do this survey?
Yeah, that's a great question, actually. I think there's not a lot of situations where I would say not doing it. There's one that I can imagine, but I can make an argument saying you should still do it. I think having a baseline information about where the frontline clinicians sit on this issue is vital. And we don't yet, as an institution, have the infrastructure, the resources to invest in some of the implementation to improve these issues. The hardest one probably being getting access to some of that cost data, especially direct cost data, can be challenging, because if we start using the survey, activating a body of people who then want that information and we can't give it to them, it might actually make some backlash to say, well, now we know this is important, and guess what, our leadership can't support it. And so it's more visible to them. That might affect culture in itself. But I think that in this day and age, with improvement going forward and how much we hear about this topic in the media, I don't actually think that there are huge downsides to doing this. One thing I think is timing, though. And I think if you ask that question about when is the best time someone should do it, I would say that launching this kind of survey at a point when you do know that there is some buy-in from the leadership in terms of investing would be key, so that you don't end up in that exact situation that I just mentioned. And again, cost access data is probably the hardest one of them as a higher hanging fruit to capture. There's so many other items on this survey that are not, and that are at the point of care of education, creating trainings, teaching these cost conversations that are doable, or doable at a division level as well.
Great, thank you. And again, would encourage anybody else to jump in with a question or comment. You can either chat in the chat box or just unmute your phone yourself. Just give it a second.
This is Kelly, and I have one more question. I know that you said there's no benchmarks, much like Choosing Wisely. Mm-hmm. But are there areas that, or are there, I guess, ranges where you'd say organizations should definitely work on things? Like we always say, if you have more than 40% overuse of something, that's a great place to start. So do you have any sort of ranges that you could recommend?
Mm-hmm. Yeah, and I think they'd have to be specific for the items. So I'll kind of group them together by the domains that we discussed. So when we talk about having a blame-free environment, this data now has been published across our 12 sites in 2 studies, one in the Journal of Hospital Medicine and one in Academic Affairs. But when you look at some of those more raw data across those 12 institutions where people range, it is around 60% or so. And so I think being able to compare it with at least those institutions gives you a sense of how far are you off from potentially a few of these other institutions. But I think the ranges for blame-free environment, most institutions are falling between about 50 to 70%. I would say in cost conversations, it's almost around 50% where people are reporting that they feel like, people feel either uncomfortable or comfortable having those conversations. And then the cost and data transparency are very low. I mean, most institutions are reporting that they have availability to this data or they know where to look for it at about 10 or 15%. So the goal you could say would be that if someone made this cost information available, you could move from 15% all the way to 80 or 90% very quickly with that type of intervention. But I think we can't say that there's a specific goal range. You could say that all of them should ideally be closer to 80, 90%, but I think it's more about improvement over time and knowing when your intervention gets implemented by how much we want to move forward. I think doing that comparative analysis, knowing the state of this field and knowing where the percentages fall for these different domains can be helpful. And I'm not commenting on the one about leadership and health system messaging because there are 18 items and each one are so different. But we do see ranges normally in these other institutions between about 30 and 70%. So just having those numbers might be helpful to give you a sense of if your own institution is kind of an outlier.
That's super helpful. Thank you.
Great. This is Lisa again. Other questions, comments? Well, I might ask another one. What about in terms of, and you've talked a bit about this, Reshma, along the way when you were presenting the survey, but any particular stories that stand out for you in terms of institutions, divisions, organizations using the results of the survey in a focused way to make an improvement?
Yeah, No, that's actually a great question. So one of the institutions that we tested this out, and it actually brings up a whole other issue around how this is used amongst residents and trainees. So they did the survey amongst faculty in internal medicine, and that was amongst the hospitalist division, and actually found very similar scores in very similar domains that the residents reported. The residents rotate through different institutions, though. When they're reflecting on their experience, they're looking at their educational kind of milieu, their learning environment across different centers. And one thing that was noticed was that amongst the residents, when they reported their experience in a county hospital setting versus the university-based setting versus the community hospital setting, that there was a little bit of variation. So what we know is that faculty versus residents, we find very similar findings within an institution, but residents who cross institutions are different. And what we find, and this correlates with studies such as Chen et al. had written a study about this, looking at, you know, the region that we live in using the Dartmouth Atlas in terms of their spending patterns and how that correlates, you know, 10 years down the line in terms of affecting practices is definitely seen. Some of the stories that we found, though, was that residents who are working in academic centers tended to report that the overt training and the discussion around high-value care was pretty visible between researchers, grand rounds, lectures. But when it came to actually seeing implementation of interventions from leadership, that's where things were falling short. Versus in the county settings, what we found was the opposite, was that there was actually quite a bit of high scores being reported when they looked at institutional buy-in for value-based implementation. But where the struggle was actually in overtly the frontline clinicians feeling like they were aware of when it was happening. So there weren't actually as many formal trainings or some of these decisions being overtly placed in front of them. It was almost like it was being done on the back end by the electronic medical record or through the system changes. So a very different story. And then the county was actually very different in that the residents there actually scored a little bit lower on a number of these domains. And it's actually challenging, I think, in the county setting, and this is what was surprising, to use some of these results because the value-based purchasing score itself, which is what we validated it from, has some limitations in terms of how that score is adjusted for safety net type of medical centers. And so we did some additional interviews outside of, you know, the studies that were published, or and what we did is in follow-up actually asked the residents, well, at the county centers, where are you reporting? Why are you reporting some of these changes that are there? And I think what it is it's not that the institution is, you know, they're feeling like they're not supporting this initiative. It's actually the opposite. They feel like when we talk about value interventions affecting patient out-of-pocket costs, the residents and the clinicians are actually feeling like the county institutions are actually doing quite a bit to think about how their patients are going to adhere to medications and pay for them. But it's more the system interventions that are different in that sometimes the efficiency of being able to get records from an outside facility take a while, and so they'll just reorder an MRI or a CT scan upon admission or upon transfer. And those kinds of stories is actually what came out. So I think in terms of the survey, we got a little bit of a clue that there's a special story around what's happening in county facilities, but the qualitative information we pulled from this actually gave a lot more fruit to that. So I think the most interesting finding from this was that, and I think there's a lot of opportunity for research using these surveys or using qualitative work back in those county settings. So what they did in one of the programs was actually target the residents at these different settings. So the residents got a uniform experience. So when they rotated through the county setting, they were being taught more about how to make changes with workflows so they weren't over-ordering and duplicating orders. When they went over to a community setting, they were getting more formal training during lunch hour teaching sessions. And when they went over to the university center, they were trying to get residents more involved with implementing interventions within their residency program. And so that we tried to create balance based on each specific site and what each area there was where things were falling a little bit below mark.
Great, really helpful. Thank you. It's a great story. All right. Others? All right. Well, with that, we might be nearing the end of the hour here. Actually, can you just say one more time, and again, you probably said already, but if somebody wanted to start using the survey tomorrow or next month, what's the next step they would take? And could we chat a link at all?
Yeah, absolutely. So actually in the PowerPoint, if they're going to be distributed, we do list a couple times where the website is to access this survey. I'll just read it again here. It's www.highvaluecareculturesurvey.com. And on there, you'll be able to access a description of all 4 of the domains, access the papers about the creation of the survey and kind of the validation that went behind that. And you'll also be able to access the survey and the scoring sheet there. So I think the first thing would be to go ahead and look at that site. There are a number of people who have started using the survey, and I think if you're about to embark on that kind of effort and want to contact myself or others, a part of our team, we are happy to, get on the phone and talk through how to use this, or to put you in contact with other groups that have embarked on this as well.
Terrific. Thank you. And thank you, Kate, for just chatting in the link to everyone there as well. And we do always share these slides, so folks will have access to the information that way as well. So with that, I guess I'll say thank you very much, Reshma, both for your work on this and for being willing to share it with us and doing a terrific job in the presentation today, and everyone to joining. And Kelly, I'll turn it back to you.
Terrific. I'll echo my thanks, both to Dr. Gupta, everyone for joining, and Dr. Letourneau for being able to manage her somewhat frustrating technical difficulties and get on.
Always a new one.
As we mentioned, we'll be sharing the recording on Workplace. If you are not on Workplace, you can email Kate Carmody to get on Workplace, or if you'd just like to receive a link to the recording, you can chat us right now, email Kate or myself, and we'll do it. I invite you to join us next month to learn more about Virginia's statewide program to reduce low-value care called Smarter Care Virginia, and appreciate everybody for joining us, particularly Dr. Gupta. Thanks so much, everyone, and have a great night or day.